Okay, good morning, good afternoon, good evening po sa lahat. Saan man pong panig kayo naroon sa mundo. Welcome to our 260th episode of the Health Updates webinar series brought to you by the University of the Philippines. Thank you for being part of our credible online community, and to all those who have just discovered us today, welcome po at sana po marami po kayong matutunan dito sa ating very, very important topic. Although hindi po siya summer ngayon, no? It's really one of those summer kuno po ng diseases po, no? But hopefully we'll be able to tackle them in much more detail for today's and this week's webinar po, no? So we're in the ophthalmic landscape po sa Pilipinas, necessitates po continuous really learning of all of these things, such as very ubiquitous, lagi po natin nakikita, and highly transmissible po na ocular surface disease na tinatawag na conjunctivitis, o mas kilala po bilang sore eyes. Sinasabi po, it's a self-limiting condition po, no? Pero meron po kasing mga recent localized outbreaks dahil din po sa mga environmental factors, maybe population density and other evolving pathogen profiles that could cause din po, no? Then have us need to learn more about how to manage po itong mga tinatawag po nating sore eyes. We're very, very fortunate for this week that we have a distinguished panel of experts po, no, who will help us navigate ano po ba yung mga maybe advanced ophthalmologic interventions po, no, and how to better understand the complex etiologies of acute and chronic conjunctivitis po. We move beyond basic viral and bacterial classifications to address less common but potentially sight-threatening forms like EKC, mamaya pag-usapan po natin yan, and refractory allergic subtypes. So sit back and relax, and sana po marami po kayong matutunan sa ating webinar for this week. This is the Health Updates program. I am your host, Dr. Raymond Francis Sarmiento. Always a pleasure to be with all of you during our regular Fridays. Also, my honor and pleasure po to host this program together with Dr. Stella Marie Jose. Ma'am Stella.
Good afternoon, everyone. Good afternoon, Raymond. And hello to all our participants here in the live broadcast of the Zoom webinar. And to all those watching via TV UP YouTube channel, as well as the UP System Facebook page, the TV UP Facebook page, and of course, those watching from TV UP Signal TV Channel 101. Our main speaker today is Dr. Ruben Lim Bonchong, who is the chairperson of the Department of Ophthalmology and Visual Sciences at the UP College of Medicine and at the Philippine General Hospital. Our reactor is Dr. Reginald Robert Tan, who is a practicing cornea and refractive surgery specialist and is also a clinical associate professor at the Department of Ophthalmology and Visual Sciences at the UP College of Medicine and the Philippine General Hospital. In this week's episode, we will discuss how we can safeguard visual acuity and improving overall public eye health outcomes. But before we go to our presentation, Raymond will introduce our person on the street video. Back to you, Raymond.
Thank you so much, Ma'am Stella. So for a person on the sheet video, it's a very, very short video po, no? Maybe less than 5 minutes. Just to check po what the public knows about this particular disease. So marami naman po sa atin na nagkaroon na po ng sore eyes. So the question that we pose, at least for this week po, no, are as follows. Ano po ba ang alam ninyo tungkol sa sore eyes or conjunctivitis? Sa tingin po ninyo, paano po ba nahahawa ang isang tao sa sore eyes or conjunctivitis? Kung kayo po ay nagka-sore eyes na, kailan po ba dapat pumunta sa doktor o espesyalista sa mata? Ano sa tingin ninyo ang sanhi ng pagkakaroon ng conjunctivitis or sore eyes? At sa palagay po ninyo, ano ang dapat gawin upang gumaling ang mga matang may sore eyes? Please watch this.
Sore eyes, parang yun yung, kapag namumula kasi yung mata, suspected na siya as sore eyes. Yung parang ang kapag halimbawa nagkusot ka or masakit yung mata mo or nagbuta ka, yun, inisip na namin may sore eyes ka na.
Ang idea ko, sir, regarding sore eyes, kapag yung biglang namula yung mata mo, nangate, at saka yung nagmumuta na yung mata mo.
I just know that, at least I remember that conjunctivitis is caused by bacteria and it's mostly by contact. Dirty fingers essentially, or just in general, just, touching your eyes.
So, I'm coming from the lens of a nanay sa akong mom. So, of course, we have to make sure that the environment is clean, especially, hand washing. At least that's what we were told especially when my kids was much smaller. Because then they would hold things and then they rub their eyes.
Pag yun sobra na sa yung pamumula or hindi ka na makamulat dahil sa pagmuta, parang yun ang time na pwede ka na magpa-check up talaga sa doktor.
Usually, so based on experience po, pag gising sa umaga, yung biglang hindi ka na makamulat kasi yung mata mo, punong-puno na ng muta or talagang sobrang pula na.
Because I think that this might go away in a day or two. At least that's why I remember it. The persistence is definitely something to bring up, or at least I don't know, like vision changes, like vision loss, or straight up just being like your eyes being shut off and like being unable to use it.
That is also, you can get it from someone who has it. So you avoid being too close to that person. And it's more like the person's touching his eyes and then touching things. So these are like things that the doctor would tell us to advise us as parents.
Halimbawa, may na-encounter ka na may sore eyes na siya, tapos yung nahawakan mo or nagkausap kayo na touch, tapos nagkusot ka ng mata, parang yun, natatransfer na yung niya, sore eyes.
Pwede sir sa paligid po, pollution or yung mga nahawakan mong maduduming bagay sa kamay mo, hindi mo paghugas properly ng kamay mo.
But also, I think in general, just being able to like wash your face, because I think like bacteria or oil buildup could definitely host or be a vector for a lot of bacteria.
First, when in doubt, really consult a doctor. Because then you're sure you don't self-medicate and then especially if the eyes, it's very important.
Pwede kang maghilamos o mas maganda kasi maghugas ka palagi ng kamay para hindi kayo mahawa. Tapos, water, mo lang yung eyes mo. Maghugas ka lang ng mata.
I think it also might be bad in the long run if you're pretty consistent or like constantly how you use it. So yeah, I think there's some first aid relief or like quick relief. Try like keeping your eyes closed for as long as you can or something, or like I honestly don't know, but like definitely the eye drops are the only thing that I remember from my experience.
Para sa first aid, maghilamos po gamit ang malinis na tubig, tapos maghugas po lagi ng kamay.
See a doctor. I think it's always good to be guided by what the doctor is going to tell us to do. And if you have it, definitely, then follow the doctor's orders and be considerate to other people. Keep your distance from them. Don't rub your eyes. And follow whatever medication and rules and the instructions from the doctor. Thank you.
Okay, thank you so much to our webinar team po. Marami po tayong natutunan sa kanila at marami naman po palang alam na ang ating mga interviewees, at least for this person on the street video. So just a little bit of housekeeping po, all certificates of attendance po for health updates webinars have been sent out na po, and obviously you'll remember that only those who have watched at least 50% of the webinar duration will be eligible to receive the certificates. We have already addressed all of the concerns, wala naman po, but if you have any concerns or questions lang po, please email us at our up.edu.ph email account. For our webinar today, we'll be having a standard panel discussion format, and after speakers have presented, that will be followed by a Q&A session. But if you already have any questions, lingering questions po in your mind, you feel free to put them in the comment section po sa ating YouTube or here in the Q&A section in Zoom webinar po. We'll get our webinar underway. Dr. Stella Jose will introduce our main speaker.
Today, we are fortunate to have Dr. Ruben Lim Bonchong, who is the chairperson of the Department of Ophthalmology and Visual Sciences. Let's welcome Dr. Ruben Lim Bonchong.
Hello, good afternoon. Okay. To our host, and of course, first of all, thank you very much to TVUP for inviting me to this very prestigious webinar. So and our reach This is the only time ngayon ko lang nalaman na grabe pala ang reach ng TVUP, no? So it's international. So for all our kababayans out there, magandang araw po sa inyong lahat. And for all those non-Filipino, non-Tagalog, non-Filipino speakers, okay, a good day to all of you. Okay, so let us begin our talk for today. Let's share the slides. All right, okay. So as mentioned earlier, no, ang topic for today will be on conjunctivitis, no? So sari-saring sore eyes, solving the conjunctivitis puzzle. Kasi nga ang nangyayari kasi, no, it's often that everybody says na hindi na, ang dami-daming akala ng lahat ng tao, no, lahat ng red eye, sore eyes na kaagad. Okay, so that more the purpose of this talk, no, is really to educate the healthcare professionals, no, on how to diagnose the different types, no. Sari-sari po ang type of conjunctivitis. And you don't really need sophisticated or expensive tests, no. Ang kailangan nyo na lang will be your basic skills, no, like history taking, asking for the symptoms, and spotting the signs of the patient. And as you will know later, no, all those alone will be enough for you to come up with actually a very accurate diagnosis. And after all of this, no, we'll provide information, no, on the basic management of the different types of conjunctivitis. So typically, we sit the patients like this, no? Patients comes in, tapos you get the history, 5 days duration of eye redness with discharge and crusting, accompanied by discomfort, mild pain, tearing, occasional itching, and swelling. And there's no significant blurring of vision. So typically, ang unang tatanungin natin ba, is this conjunctivitis or not? No? Okay, so if yes, what type is it? So those are the first thing that you would ask, no, if the patient comes in, you suspect, is it conjunctivitis? Kung conjunctivitis siya, ano po yung cause? Okay, so let us proceed step by step to solve the conjunctivitis puzzle. Okay, so you know you have solved the puzzle, okay, that you've done your job, no, when you have established the presence of conjunctivitis and you have determined the etiology of conjunctivitis. So it's not enough to say that you have conjunctivitis. You have to know what is causing the conjunctivitis. Is it microbial? Is it allergic? Is it immunologic? Is it traumatic or toxic? So under the microbial or infectious, no, you have your viral, you have your bacterial, and your chlamydial. What are your most important clues? Okay? It's redness, of course. No? People are always very concerned, no? Kung namumula yung mata, no? It's a very alarming sign. Okay? Actually, it's more alarming than blurring of vision. Typically, patients with blurred vision, they do not consult early. No? But if they have patients with red eye, no, not persistent, they will really seek medical help. No? And at the same time, you should have discharge. So in other words, redness alone without any discharge, no, the chances of a conjunctivitis is very, very small. No? Then you have to think about the other causes of red eye. But if you have redness and significant discharge, then you're almost sure patient has some form of conjunctivitis. So ito kasi yung mga red eye differential, the other causes of red eye. No? So if you have a foreign body in the eye, no, of course the eye will be it's a form of trauma, no? So it will be irritated, the eye will get red. Contact lens overuse, contact lens abuse, no? And contact lens related complications, no, will also give you red eye. A bleed under the conjunctiva is really very red, no? This is actually very common, no? More common than all the conjunctivitis, no? Patients on blood thinners, patients who had eye rubbing, okay, patients who had basalva, okay? And then they have the small blood vessels of the conjunctiva bleeds, no? And there's really blood collecting under the conjunctiva. Okay, it's one of the most common reason for consult at the clinic and also the emergency room. No, other causes na red eye na walang discharge is scleritis, no, or episcleritis. The eye is very red. However, the patients will not complain of any form of discharge. Any infection on the cornea or any trauma to the cornea will also give you red eye, but only very minimal discharge. Okay, inflammation inside the eye, that's called anterior uveitis, no, inflammation of the iris. The eyes gets red. Again, there's absence of discharge. Acute attack of glaucoma, same thing, severe pain, severe eye redness, however, there is no discharge. And of course, other forms of trauma, corneal laceration, okay, or chemical injury to the eye, those will give you some form of red eye. And however, the discharge is not very significant. They might have tearing, no? Tearing is not discharge, no? So we'll talk about that later on. Okay. So what are the key questions to ask, no, when you're suspecting that this patient might have conjunctivitis? When did the redness and discharge start? Okay, so the duration, no? When did it start? No? How long has the problem been going on? Is it 2 days, 3 days, 5 days, 2 weeks, 1 month? Okay, what is the characteristic of the discharge? Not all discharge are the same. Okay, iba-ibang klase yan, no? And we'll talk about that later. Was there any form of eye trauma? Okay, may pumasok ba sa mata? Natamaan ba yan? May tatalsikan ba yan by any substances? Was patient exposed to someone with similar conditions? So if you're thinking of something very contagious, this is very pertinent in the history. Is the condition recurrent? Okay, does it occur several times over the year, or is it seasonal? Okay, so has it been going on for years? No, is there prominent itching? Okay, aside from redness, discharge, what is the degree of the itching? Is itching the major symptoms the patient is presenting? Is there any associated systemic complaint, no? Like upper respiratory tract infection, my history of fever, any note of any skin lesions? These are very, again, important in the history. And lastly, the history of sexual history. Your sexual activity is very important because sexual activity is one of the most common cause also of acquiring, no, and spreading, no, infectious type of conjunctivitis. Okay, so I mentioned earlier, it's important to note onset and duration. No? So bakit ba? Okay, so if you have redness and discharge, you can divide and actually narrow down the etiology, no, based on the duration. Okay, so if it's hyperacute, okay, like nagsimula lang 1 or 2 days nagpatingin na, no, grabe ng ang presentation, no, then you will think it's gonorrhea or is it due to a chemical burn trauma. Okay, hyperacute yan, very, very rapid onset. If it's acute, if it's 2 to 4 days, no, from the start of the symptoms, and then they consult because they become they become a bit more severe now. So you think of adenoviral or your Stevens-Johnson syndrome or your TEN, and of course gonorrhea is still one of the most possible etiology. If it's acute, that's around 5 to 14 days, no. So it's been going on for a week now, hindi pa gumagaling, so papatingin sila. Then you think of Haemophilus, Moraxella, Streptococcus, Staphylococcus, and chlamydia. Okay, for the chronic, ito long playing, no, 2 weeks na, 3 weeks na, 4 weeks na, parang hindi pa rin gumagaling. Then you think of chlamydia, tuberculosis, molluscum contagiosum, bacteria na Moraxella, and others are not infectious, no, allergy, no, or your vernal keratoconjunctivitis, again Stevens-Johnson syndrome, or in a chronic foreign body on the eye. And recurrent, where the symptoms of redness and discharge occurs, no, several times in the year, or it's seasonal, then you think of allergy, or if it wax and wings, and you can talk of staphylococcal, and of course, vernal is a more severe form of allergy. Ito naman yung type of discharge, no? So again, as I mentioned earlier, not all discharges are the same, no? So you have to describe, is it serous or is it serous or watery, mucoid or stringy, mucopurulent or purulent? So here you can see the pictures, no? So kung serous and watery, okay, patients who had red eye, and then it's very watery, no? So you think of, is it adenoviral, is it allergy, or due to toxic? When the patients come in with mucoid, no? Okay, a bit parang sipon, okay, with stringy and ropey, no? You can actually, it forms into string. Then you think of allergy, okay, or toxic, or even chlamydia. Now, when they are mucopurulent, no, yung talagang it's thick, but it's not yellow, okay, and it's whitish, no, that's mucopurulent. It's Haemophilus, staph strep, chlamydia, or Moraxella. However, when they come in very purulent, it's like pus, no, it's thick and yellow. Then chances are 99.9% of the time, no, it is probably due to gonorrhea. But some few cases will be due to streptococcus. What are the other points that you have to look for? No? So tapos na tayo sa duration. Okay, you have established your redness. You have identified the discharge. Now you look for the different signs. Okay, there are different signs that you look up. Yes, you might need a slit lamp to see some, but a lot of these are quite gross. Okay, with the magnifier and good light, you'll be able to identify these lesions. One of those is papillae. Papillae is very important. All types of conjunctivitis will have papillae. Now, as I teach all my students, no, if you don't see papillae, again, the chances of conjunctivitis is small. Then the other one is conjunctival follicles. No, you see that in all those conditions. It is very diagnostic because not all conjunctivitis will develop follicles. Now, if you see follicles, then you can narrow them down to adenoviral, chlamydia, moraxella, molluscum, or toxic causes. And presence of membranes. Okay, membranes can be seen in adenovirus, gonorrhea, strep, haemophilus, chlamydia, and trauma-related like chemical burn, and of course your Stevens-Johnson syndrome. A very rare presentation is granuloma. No? Typically, you see that in tuberculosis of the eye, no? And also in Parinaud syndrome. A palpable preauricular node is seen in adenovirus, gonorrhea, chlamydia, and if it's quite visible, quite prominent, that is usually seen in what we call in Parinaud's oculoglandular syndrome. It's also important to observe and look for the changes on the skin, on the lids and the lid margins and the rest of the body. If you see skin changes, it might be due to moraxella, due to staphylococcus, due to molluscum, or due to demodex, especially those located at the lid margin. Okay, so papillae is seen, no? Just to emphasize, no, almost all type of conjunctivitis. All types of conjunctivitis will have papillae, but again, not all papillae will look the same, no? You have fine velvety papillae, you have large papillae, you have cobblestone papillae, and you have your giant papillae. So you really have to pay attention and find out and look for and identify the type of papillae you see. Follicles, again, is not present in all type of conjunctivitis. You see that in adenoviral, chlamydial, moraxella, galactocysti, and molluscum. So these are lumps, no? So when you pull the lower lid down, no, mapula siya. Tapos when you see this lumpy lesion, para may sago, daming sago, no, na naka on the conjunctiva, no, they are lumpy, dome-shaped, okay, and then those are your conjunctival follicles. In contrast, no, the papillae are vascular changes, no, these are, and sometimes with fibrosis, kaya lumalaki sila. However, ang follicles, these are lymphoid tissue, no, these are activated lymphoid tissue underneath the conjunctiva, kaya they come together with preauricular and submandibular lymphadenopathy. Magkakaroon ka ng lymphadenitis kasi kasama yan. Okay? So just to put them side by side, hindi magkapareho ang follicles and papillae. When you look at the upper lid, okay, ito may papillae. However, there are white lesions, no? There are deep white lesions. Those are follicles that are buried deep, okay? Hindi sila nakaangat, no? Because the conjunctiva here is very tight, no? In the lower lid, the conjunctiva is loose, no? So the follicles will protrude out. Papillae are like this, no? Little red dots, no? Because these are vascular dilatation, okay? And over here also in the lower lid, these are all little red dots. Okay? That's why they appear very, very red. Yeah, you have this redness because there is vascular dilatation. Membranes can be helpful also, but it is important to identify it because it can cause a lot of problem if we do not remove the membranes, no? So you see that in different etiologies, no? The point here is membranes has to be removed, no? This has to be referred to an eye care professional. An ophthalmologist is crucial, okay? Because if you don't remove the membranes, no, you can get into more ocular surface complication. Granulomas, again, it's not very common, no, but again, it's in very rare cases. No, we see a few cases of tuberculosis over the years, no, of the conjunctiva. That's a picture on the left, okay, and on the right is your Parinaud's ocular syndrome. Again, this is a very highly visible preauricular node. This is a case of Parinaud's, no. So anytime you suspect adenovirus, chlamydia, or gonorrhea, do not forget to palpate for the preauricular node. Okay, they usually enlarge and they are quite tender. Skin changes. Okay, so on the lid, on the corner of the eye, no, if you see these changes at the corner, you call it angle maceration. Okay, that's very specific for moraxella. If you see changes of fibrin crust, no, nare-red yung lid margin at the base of that, you see a lot of this crusting. Okay, that's very pathognomonic of staphylococcal blepharitis. You see bullous eruption. Okay, that's an SJS or also in your TEN, and umbilicated nodules around the lid margin, around the eye, no, that is seen in your molluscum contagiosum. So let's put them all together. Let's do some exercises. Okay, so here we are. Let's try to solve the puzzle. Okay, so you have a patient coming in with serous watery discharge, diba? So red, given na kasi yung redness, no? So zero watery discharge, and you see follicles acute, no? Very, no, so less than 5 days lang. Okay, very, very significant na yung presentation. Okay, and you flip the upward, may papille, or definitely may conjunctivitis. And then you palpated, there is preauricular node, my membrane, and then there are areas of petechiae or tiny areas of hemorrhages. Okay, this is a classic case of your adenoviral conjunctivitis. This is the most common type of viral conjunctivitis. Okay, this is what we call in the layman, no, yung sore eyes, no, or in the Western world you call this the pink eye, no. Okay, it's the most common infection of the conjunctiva. It's self-limiting, 7 to 10 days to 14 days. Okay, the most important, tears and discharge are highly contagious, so it's a hand-to-eye contact. The transmission is hand-to-eye contact, never eye-to-eye. It's not airborne. Okay, the virus, hindi siya lumilipad, no? Hindi siya tatawid o tumatalon from person to person. Okay, as mentioned in the video earlier in the interview, tama sila. Strict hand washing is very, very important. Okay, we learned this through the COVID pandemic. Okay, make it a habit to have strict hand washing anytime you have red eye. Okay, and then, or not only with water, soap and water, you can use alcohol. Okay, better to use ethanol base, no? Okay, ethyl alcohol rather than your isopropyl, because some virus will not be totally eradicated with your isopropyl alcohol. Okay, you apply cold moist compress if the eye is very irritated, no? Because very irritating, it's like a severe cold. Okay, your eyes like congested, it's very uncomfortable, no? So we for first aid measure, malamig, cold moist compress as often as possible, and wait it out, no? It will heal. Okay, however, sometimes the patient's very symptomatic, then you have to see an eye care specialist, and we give very limited use of steroid antibiotic drops, no? So this is very selective, no? It's not something that we would recommend for every patient. Okay, you have to be very selective about this, because we want a cautious use of antibiotic and steroids, because you don't want other types other complications to arise, no, from the use of steroids. Okay, so that's very important. For the next case, no, so you have a hyperacute. So hyperacute 1 or 2 days, tapos purulent discharge, no, and severe conjunctival chemosis. Okay, as mentioned earlier, okay, purulent discharge 99.4% of the time, that is your adult gonococcal conjunctivitis. They might have a positive history by direct sexual contact, or it can be self-inoculation. How so? Patient might be suffering some form of meron na silang gonococcal urethritis. It might be subclinical. Tapos they develop red eye, and they self-medicate, they self-use, they use urine wash, no? They get their own urine, and then they drop it on the eye, no? So that is one way of inoculating gonococcus into the eye. So again, just a sort of caution, urine is useless, no? Okay, for the eye, it can cause harm, no? If your urine has bacteria, that can cause infection of the conjunctiva. In newborn, okay, same thing. You see hyperacute, less than 5 days of life, panganak 2 days, 3rd day, there's purulent discharge na in the eye. Okay, that again, unless proven otherwise, is almost 100% neonatal gonococcal conjunctivitis, and you have to move very fast on this, because untreated gonococcal conjunctivitis can lead to corneal melting, and you can cause blindness, no? We have several patients of that at PGH over the years, no? And we had to save the eye by doing corneal transplantation. So you have to irrigate conjunctiva to remove the discharge, no? Treatment of choice for adults, no, is ceftriaxone, almost 1 gram IM, single dose might be enough. Okay, if there is severe complication, okay, we give ceftriaxone 1 gram IV every 12 hours for 3 days. Ceftriaxone in children is much lower, you know, you give it by weight. Other choices will be oral, and if they have allergy to ceftriaxone, these are your other medications you can choose. Then we give topical fluoroquinolone drops and aminoglycoside drops, okay? And we never give steroids for acute cases of severe gonococcal conjunctivitis. Another case of conjunctivitis, patients come in, another baby, beefy red papillary conjunctivitis with mucopurulent. So it's not purulent, the eyes are red, it's purulent. Tapos sabi ng nanay, okay, tapos occur after 5 days and may bleeding. Doc, namumula tapos nagluluha ng dugo. Okay, because may membrane siya. So when you have membranes, when it gets dislodged, it will bleed. Okay, so if you get this, a newborn, more than 5 days with eye redness, with severe eye redness, and see membrane and sometimes bloody tears, this is again almost 100% neonatal chlamydial conjunctivitis. In adult, it's different, no? Okay, so they occur. It's actually quite chronic because it's smoldering, no? It's not very hyperacute like gonococcal. It will take them several weeks before they will seek consult. They will say, bakit ang tagal-tagal na hindi pa gumagaling, no? So chronic follicular conjunctivitis, and you see very prominent follicles. Sometimes you see mucoid discharge and limbal swelling. And again, positive sexual history is quite important. No, this is actually the most common cause of sexually transmitted conjunctivitis. No, okay, your chlamydia. Okay, it's more common than gonococcal. But of course, when we give patients with gonococcal, since chlamydia is quite common, no, we treat chlamydia at the same time, no, in all patients with gonococcal conjunctivitis. So very important. Chronic follicular conjunctivitis, 2 weeks, 3 weeks, 4 weeks, months. We have patients going on 6 months, hindi gumagaling. Okay, all you do is get a good history. Then if there's a positive sexual history, then you might have hit the jackpot and will able to treat the patient. So these are the treatment. No, for infant, we give topical and oral erythromycin. Okay, we do not give your doxycyclines, no, to infant. For adult, okay, topical moxifloxacin or levofloxacin and oral azithromycin, 1 gram single dose is the drug of choice. Okay, typically, the patient, ask the patient to come back. You can actually repeat it, okay, if you need to. Okay, but typically 1 dose is enough. And never to treat for infants, no, because they got it from the birth canal. Don't forget to treat the mother, or the parents and all the partners, no, as well as in your chlamydia. Again, in gonococcal also, no, you have to treat the part that's a form of our public health responsibility. You try to go case finding, no, and find and treat as many patients as possible so you do not spread the infection. So now you have a child, no, mucopurulent pediatric age, no, hindi na siya baby. Okay, mucopurulent discharge with papillary conjunctivitis, with matting of the lashes with chemosis, meron siyang orty. Okay, tapos may subacute onset, around 5 days a week. Okay, if you see this kind of the symptoms and this history, now then you think of Haemophilus influenza conjunctivitis. Okay, typically it comes with your upper respiratory tract infection. And here's now an adult, an older patient, an elderly patient. Ganun din, mucopurulent discharge with papillary. Okay, tapos may duct obstruction. Then again, it's chronic. It may be acute or chronic in adult. Then we think now of streptococcal. Okay, the chances are it's due to streptococcus. So you have, that is again it's not actually very common. No? Bacterial conjunctivitis in adult is not common. Usually it's secondary to other ocular problem. Here, chronic follicles and papillae. Okay, matagal-tagal. No? Chronic follicle, more than 2 weeks, more than 3 weeks. Okay, and then you see angle maceration. So complete eye exam is important. Even the lids, the corner, lahat yan importante yan. Okay, you see maceration and you have some form of mucopurulent discharge. This is actually not difficult to diagnose, no. But again, it's missed because especially my residents, no, they miss looking at the corner of the eye. No, this is due to moraxella. Okay, now another patient with chronic papillae, mucopurulent discharge, and you see all those lid margin changes on the skin. There's crusting and ulceration, okay, with mucopurulent discharge at the bilateral, it can be unilateral or bilateral, and it involves all the entire lid margin. Again, what's on the skin is due to staph conjunctivitis. So starts from staph on the skin, on the base of the lashes, from staph blepharitis, and it spills over into the conjunctiva. Okay, it's very important. It's common in a lot even in pediatric age group, 5-year-old to teenagers. No, this is quite common, and patients with chronic untreated staphylococcal blepharitis now can lead to corneal complications because of immune activation from the toxins that are introduced into the tears, and because of this chronic interaction of tears on the cornea, it can cause corneal scarring and corneal melting and corneal perforation. So again, very important. And typically, and most of these are children, okay, 10-year-old, 11, 12 years old, no? So it's important to treat infection of the lid margin, especially due to staphylococcus. So how do you treat bacterial conjunctivitis in general? Haemophilus influenza and moraxella, you treat with topical antibiotic drops, your aminoglycoside, the tobramycin, gentamicins. So it's 4 to 5 times for a week. When it's streptococcus or staph, then you give your newer generation fluoroquinolone, like your levofloxacin and your moxifloxacin. Okay, and again, do not give topical steroids. Okay, in cases of bacterial conjunctivitis, it is not necessary. Okay, so we're done with the infectious part. No, this more immune mediated. No, I just want to emphasize this because this is one of the conditions wherein you can lead to permanent blindness in both eyes for life. Okay, and this is very, very difficult to treat. And the only way to prevent severe ocular surface complication is early identification and early intervention in the treatment of the eye complication. Okay, here you give steroids, no steroids on the eye during the acute phase. It's almost every hour round the clock for several weeks, and then you have to strip all those membrane. You have to control the inflammation, or else a lot of the tissues on the ocular surface will be destroyed, and that will lead to corneal scarring and blindness. Here again, another immune in a sort of a ways immune mediated, mucoid and stringy discharge, papillae. Okay, and then it's just very mild, hindi masyadong mapula. It's not as red as in your viral conjunctivitis, and you see this pinkish, boggy conjunctiva. And then itching is very prominent, and it's recurrent. They will say, minsan paulit-ulit, no? Tapos in the family history, in their personal medical history, they have atopy, asthma, morning rhinitis. Okay, so if you put them all together, that is your seasonal or chronic allergic conjunctivitis. So itching, redness, mucoid discharge. The eye's not so red. Okay, there's no purulent discharge, there's no mucopurulent discharge, and itching, they want to rub. Okay, then this is your allergy. Okay, now this is the more severe form of allergic conjunctivitis. It is seen in the pediatric age group, prepubertal, especially in male. Okay, 3 out of 4 will be male. Cobblestone papillae with ropey discharge, pigmentation, prepubertal male with recurrent itching and photophobia. Try to flip the upper lid. All you have to do is flip. And when you see those bumps, again, refer immediately to an ophthalmologist, because this is vernal allergic conjunctivitis. This condition might be self-limiting when they hit puberty. However, untreated cases can lead to corneal scarring and lead to permanent corneal blindness. So what is the treatment for allergy? Treatment is a drug of choice now. We really give you antihistamine muscle stabilizers, specifically your olopatadine. It's quite safe. It's been in the market for decades, no, and you can use this chronically, okay, without any ocular complication. Okay, in severe cases like your vernal keratoconjunctivitis, we give your topical cyclosporin at 4 times a day chronically until again a very minimal systemic absorption. You don't have systemic side effect. Again, you put it on the eye, to control the severe immune-mediated reaction of allergy. Of course, topical steroids are the mainstay of allergic conjunctivitis in terms of efficacy, but not safety. So very, very clear. We give very clear guidelines. No, use ester steroids or latoprednol. So you do not cause an increase in eye pressure and cataract development. So we only reserve this for very serious cases, okay, wherein patients are very symptomatic, okay, they cannot function, they're in a way in the form of pain and photophobia. So you want to control it early, so you give steroid drops. We give it very short term, as only when needed, okay, and you have to make sure that they follow up regularly, and the patient and the parent should understand the side effects of chronic use of steroids. So you're almost done. Okay, so these are the differential diagnosis conjunctivitis, no? So you can look at it this way, you can try to memorize and and learn it this way and read up on it. Or for me, no, again, for this is I want it more practical to everybody, no, for all levels of healthcare professionals, no. So I just made this summary. So typically, if you have serous ng discharge, tapos acute, you see follicle, and you can palpate a preauricular node, that is adenovirus. That is your run-of-the-mill sore eyes. Okay? Serous to mucoid, stringy, tapos makate, allergy. Purulent hyperacute, ang onset with history of positive sexual history, that's gonorrhea. A mucopurulent discharge, acute in onset in a child, that is Haemophilus influenzae. You have mucopurulent discharge in an adult with nasolacrimal duct obstruction, that is strep pneumo. You have a mucoid discharge with chronic, with follicles, and again, positive sexual history, that's your adult chlamydia. We have a bloody tears in a neonate, you think of chlamydia. In a boy with severe itching, prepubertal male with cobblestone papillae, that's vernal keratoconjunctivitis. A purulent discharge, redness, chronic. Okay, and you look at the corner of the eye, you see the maceration, you think of moraxella. And lastly, mucopurulent discharge with papillae, and you see ulceration at the base of the lashes, crusting at the base of the lashes, that is due to your staphylococcus. And you put this together, your conjunctivitis puzzle is solved. Thank you very much for listening, and we're happy now to entertain all your questions.
Thank you so much, Dr. Ruben Limbonchong, who's the professor and chair of the Department of Ophthalmology and Visual Sciences at UPPGH and UP College of Medicine. Sir, for the Q&A, you will be moving it after the reaction from Dr. Tan po, no? In the meantime, we'll be taking this time to greet those who are joining us. Marami po kasi nagjo-join all domestically and internationally. So right now we have those who are joining us from the Cagayan Valley Medical Center in Tuguegarao City, Cagayan, Madela District Hospital in Madela in Quirino, Orani District Hospital in Samal, Bataan, Dr. Jose Rizal Memorial Hospital in Dapitan City, Zamboanga del Norte, and Eastern Samar State University in Borongan, Eastern Samar. Also those who are joining us from the province of Laguna, Davao City, La Consolacion University, Philippines, Malolos, Bulacan, from City Health Office of Antipolo. Maraming salamat po. The province of Bataan, sa may Bicol region din daw po, and Cebu, as well as sa Tacloban, Leyte, in Bohol, thank you so much. Philippine General Hospital as well, the University of Santo Tomas Hospital. Maraming salamat po. There are also those who are joining us, avid viewers po natin from the Ryan Hall Shanex Incorporated in Bridgewater, Canada, from Juno, Sarantis, and Sutra po, no? Thank you so much. And from the Lee & Co. law firm, that's in Korea, University of Hail in Hail, Kingdom of Saudi Arabia, and Chonin Hospital in Taipei City, Taiwan. We'll take this opportunity. Now we move on to our reactor po, no, is I believe he's a corneal transplant surgeon. His specialty really is in cornea, external diseases, and refractive surgery. He's clinical associate professor at the Department of Ophthalmology and Visual Sciences at UP College of Medicine and the Philippine General Hospital. So please welcome to your screens Dr. Reginald Robert Tan.
Okay, thank you. And well, good afternoon. It's nice to be here, and like to thank the organizers for the successful webinar, and of course, thank you to Dr. Limbonchong, and thank you for allowing me to react to your lecture. So congratulations. So I know, no, for even as ophthalmologists, so this lecture is quite intimidating to us because there's really there's a gamut of diseases that can cause pink eye or red eyes. And, there are a lot of intricacies involved in each of these diseases. So, Dr. Limonchong has carefully and brilliantly explained all types of conjunctivitis or sore eyes we see in the clinic. So again, just to reiterate what he said, first, it's very important to differentiate your sore eyes or red eyes or pink eye from kuliti or sty. So sty is yung bukol sa eyelid. That's, you have a mass on your eyelid, and, that's totally different. Yun, nakuha yun from, yung sabi nila, from paninilip, di ba? Pero hindi naman totoo yun. But, joke lang yun. It's really from dirty hands, you touch your eyes, ganyan. So nagkakaroon ka ng kulite or bukol sa eyelid. So that's totally different from sore eyes or red eyes. Okay, so ganun pa lang, ma-differentiate mo na yung dalawa. You just, get a closer look, and then kung ano talaga yung pula, is it the eyeball itself or the eyelid? So that's very important. Now, what he said was very important as well, discharge and redness. So you have to have those two in order for it to be classified as sore eyes or conjunctivitis. So yun, differentiate from colitis. That's number one. Number two, in terms of diagnosis, we know that it can be a little bit difficult because a lot of diagnosis is, requires slit lamp or microscope examination. Kasi yun nga, yung mga papillae, we have to see those, follicles, we have to see those. But of course, there are a lot of clues mentioned by Dr. Lim Bonchong during his lecture that will sway you if it's viral or bacterial, or is it immunologic or allergic in nature. But we know the limitation of having like eyes. If you're seeing things with a naked eye only, best talaga is again, do not do harm. So as mentioned earlier, diba, nagulat tayo, meron palang STD or STI na napapasa with conjunctivitis. So, there are a lot of things that can cause conjunctivitis as well. So, so in terms of treatment, if you want to treat patients, be cautious when you start giving like Maxitrol or Tobradex, kasi diba, that's very common. I have pink eye or red eyes or conjunctivitis or sore eyes. So, gagamit ako ng Maxitrol on my own, you self-medicate, ganyan. And of course, my mom even is like guilty of that. Reg, pahingi ng prescription for Maxitrol. Well, first of all, she's not a doctor, diba? But yan kasi narinig niya sa friend niya na namumula yung mata, tapos nag-Maxitrol. Maxitrol is a steroid, diba? We give it to, some cases of red eyes. But yun yung common na akala nila madali lang makuha. And of course, hello, mommy, anak mo, ophthalmologist, maghihingi ka ng steroid. So parang wala lang, diba? And then nagagalit sila, of course, pag ayaw mo bigyan. Of course, mothers know everything, diba? So, be careful lang when you start giving steroids because it can lead to more harm. So we do recommend to give, at least do no harm, we give artificial tears or lubricants that are preservative-free. So you might think na, pang wash lang yan pang basa lang yan Well, actually, it helps because if you give a preservative-free, make sure preservative-free, artificial tears, it dilutes all the inflammation or the bacteria or the virus away. So it actually washes away everything. So that's yung number one, do no harm, and you do good by giving artificial tears or preservative-free lubricants. So that's number one. Very, very important yan. We always give it to all these cases, all these cases. So make sure to remember that, okay? So do no harm, just give preservative-free artificial tears. Now, if hindi nag-improve yung eye, or the eye is getting worse, or the patient's getting worse, then please just refer to your friendly ophthalmologist to have a slit lamp or a microscope examination. I think, again, yung pinaka-important. Do not try steroids or try something else if hindi nag-work. Maybe iba talaga yung etiology, maybe gonorrhea na pala yun sa mata, diba? So ibang-iba yung treatment for that. So I think that's it. So very nice lecture, and again, he simplified everything as much as possible, and lecture actually became the cornerstone of again my residency training back then. So we referred to this lecture a lot because it really covers everything. It's very extensive and it's very simplified at the same time. So congratulations, Dr. Limbod Chong. And again, thank you for the organizers.
Thank you very
Okay,
much,
thank you so
Reginald, for
much,
your talk.
Dr. Tan. Maybe we'll call in Dr. Lim Bonsiong, and then we'll start off with the Q&A, Ma'am Stella.
Yeah, so in your lecture,
Okay. First
Dr.
question, ma'am.
In your lecture, Dr. Ruben, you mentioned the types of conjunctivitis. We're not ophthalmologists, and so when you showed the pictures, parang it's so hard to differentiate if it's viral or bacterial or allergic. So ano ba yung shortcut, yung mas madaling matatandaan ng viewers natin?
Shortcut is really tanungin yun ng maigi. No? The history, lahat nasa history kung ano naramdaman ng pasyente. You can actually get a lot by just asking the patient what is the most prominent symptoms they would feel. Okay? Kasi ang sore eyes, no, or what we call viral pa rin, adenoviral conjunctivitis pa na pinaka-common. Okay? So typically that is if you think of conjunctivitis na acute, na hindi naman paulit-ulit, then you think of that first. And then you ask probing questions, no, nahawa ka ba, sa pamilya nyo ba, sa workplace nyo ba, sa school ba, merong the same, no? And that's and if it's going around, no, because they come in epidemic proportion or mini epidemics, no, so in clusters, no. So chances are that will your adenoviral conjunctivitis. Okay. So kasi other common one na madami rin is allergy, no? Okay. So kung sa allergy, itching is very prominent. Okay. Kasi sa adenoviral, hindi naman makati. Okay. Actually, they feel very irritated. Okay. Mabigat, there's this irritating feeling and it's very hard, uncomfortable. But in itching, kung prominent yon, that is allergy. No? So ito yung pinaka-common, no? Itong dalawa. Okay. So you might get this in clinical practice, in the general physician practice, no? Probably these are the two types of conjunctivitis that we'll see a lot. Yeah. Yung mga sexually transmitted, meron din, pero pockets na lang yun. Again, with sexually transmitted naman, by asking very pointed questions, so you'll be able to get into the cause.
Okay, thank you for your answer, Ruben. And this one is for Dr. Reginald naman. Alam ko baka medyo off, pero tatanungin ko pa rin. What about colored contact lenses? Kasi I see patients who do those. What is your take on that one? Colored contact lenses.
So first of
Is
all,
it bad or what?
thank you for the question. So first of all, syempre, it's okay as long as you're very disciplined to clean it and remove it after use. So wag talagang itutulog ang mga contact lens. Wait, first of all, make sure na nasa reputable brand, because we always see yung alam ko, no, sa Lazada ang dami, sa Shopee, 'di ba, ang dami. And you don't know kung ano yung sterility guidelines noon. Hindi mo alam kung baka nabutas na pala, tapos micro yun, hindi natin alam. You buy from a reputable brand, usually talaga, so at least yung sa mga optical shop, if reputable yun, at least mas maayos yun. Medyo sketchy sometimes sa online, di ba? Hindi natin alam yung quality. In terms of yung quality of the contact lens itself, we know that it is slightly lower than the good ones. Okay? So when we say good ones, maganda yung oxygen permeability. Maganda yung pasok ng oxygen, hindi nasasakal yung cornea, yung harapan ng mata when we use it. But yun, okay naman sila. They're pretty much okay. But as long as you're able to remove it, kasi yun nga, if you sleep at night wearing contact lens on, you increase the chance of infection by 8 times. So that's really crazy, no? Pwede kang mabulag permanently through the infection and the scar. So, yun lang. Make sure reputable brand and make sure
Sleep.
be disciplined about it. Always clean it, wash your hands, kanyan. Tapos, just don't sleep with them on.
Thank you very much for your answer. Back to you, Raymond.
Thank you, Ma'am Stella. Thank you so much to our
Thank you.
experts po, no? Chair from the Department of Ophthalmology and Visual Sciences, Dr. Ruben Limbonsiong. Maraming salamat. And congratulations, sir. Maraming salamat din po.
You.
And then for Dr. Reginald Robert Tan, thank you so much also for giving the time out and sharing po your insights in this very, very important topic. Right now, we'll be flashing on the screen our panel evaluation poll. And it's 5 statements po. It's 4-point Likert scale. So we invite everyone to put in your answers. We are 126 here in the Zoom. And so I'll read through it and we'll not be closing this until the end of the webinar. Number 1, the panelists demonstrated thorough knowledge of the topic. Number 2, the panelists were well prepared and organized. Number 3, the panelists spoke clearly and audibly. Number 4, the panelists used appropriate language with technical medical jargons adequately explained. And finally, the panelists contributed to new perspectives and knowledge on managing various key health issues. Okay, for next week, we'll have another exciting topic for you. Who will we have for next week, Ma'am Stella?
Next week, we have Dr. Nemi Nicodemus. He's an endocrinologist. This will be also very interesting. Please watch.
Okay. Endocrinology naman po ang topic po natin. In the meantime, you can still watch us on the playback at the TVUP YouTube channel at the TVUP Signal TV channel 101. Before we conclude our program, all health updates webinars are archived for viewing at the TVUP YouTube channel. So just go to www.youtube.com/TVUPH, or if you open your app, you go to YouTube and then you go type in TVUP. In the TVUP channel, you go to the live tab. You'll be able to see all 259 episodes. After today, it'll be 260 episodes na po ang nakalagay doon. Now, very, very short journey to another tab, which is the shorts tab naman po, because we understand everybody very busy. So we have some selected presentations that we feature in snippets found in YouTube Shorts of the same channel po natin. You can watch at your convenience. We also share in our playlist po, no, in the same TVUP YouTube channel ulit next Friday from 12 noon to 1 p.m. It's a date.
Together, we can stop preventable deaths.
So keep safe, keep healthy. See you online.
Thank you, Ruben.